good morning, or good evening, depending on which part of the world you're in. It's an absolute pleasure for me to kick our esteemed talk series for the Hamlyn Symposium off with an amazing talk from Kevin Cleary, a long-standing member of the Hamlyn Symposium community and a general co-chair of last year's Council Symposium, of course. And he actually was the guest editor of last year's special issue that we used to mark the symposium, which was published in TMRB, which also allows me to remind you all that we have a call for special issue journal papers that closes on the 30th of June, and it's centered around the topic of from bench to bedside. So you're very much encouraged to take the opportunity of the special issue to publish some of your latest work where you're looking at technologies that can affect healthcare in the broadest sense. So without further ado, I'd like to introduce Kevin. Kevin graduated from Duke University and subsequently received his PhD from the University of Texas, Austin, before beginning a rather prolific scientific journey in medical robotics and image-guided interventions. After a period at Georgetown University Medical Center, where he worked in the Image Science and Information Systems Center, if I get this right, to develop systems for minimally invasive procedures, he moved to Washington, D.C., where he's the scientific lead and associate director for engineering at Sheikh Zayed Institute of Pediatric Device Innovation in the Children's National Hospital. In this capacity, he works with clinicians and engineering colleagues to improve visualization in pediatric surgery through medical devices and robotics. And today, we look forward to hearing him share his experiences on MRI robotics for minimally invasive procedures in the bore of the magnet. It's an absolute pleasure to introduce him, Kevin, and I look forward to your talk. Thank you very much.
Okay, thank you, Ferdy. It's always hard with Zoom, you know what you're kind of seeing and hearing, but you always wonder if the other people are seeing and hearing you. So it's a great pleasure. I'm going to go ahead and share my screen and then give a little bit of an introduction here. Okay, let me just find the screen share here. And okay. And I will go ahead and put this into slideshow mode. So I hope you all can see, and I think I have the Hamlyn background. So first of all, I just want to give a shout out for friends around the world. I just looked at the list. We would all love to be together in person, but given Zoom, at least we can get together virtual. So I saw Alicia from Spain, who I haven't seen in a long time, Casper, Loris, other people, Liz from my lab, Julian, I think Elena as well too. So I appreciate you guys coming today. I'm going to go pretty quickly because I want to keep it to 30 minutes so we have some time to discussion. I would prefer if we make this a little bit interactive, where if you have comments, please go ahead and put them at any time into the chat box then, so that we can see them as we go along, and maybe we can have a little discussion and generate a little controversy to make it a little more interesting. So what I'm going to talk about is MRI robotics for minimally invasive procedures in the bore of the magnet. We all know in the clinical world that we're going towards less invasive procedures. The goal is not to do open surgery so much anymore, but to do minimally invasive procedures, or potentially even non-invasive procedures, such as high-intensity focused ultrasound for better patient care. So a little bit of outline. I'll talk a little bit about our research institute and invite you all to visit us someday when the pandemic gets better, which hopefully we're moving in that direction. Talk a little bit about the history of MRI robotics, and then I'm going to present 4 different systems we've been working on. 3 are body-mounted systems, all with the bot theme, so to speak. Arthrobot for shoulder arthrography, Painbot for back pain, BoneBot for long bone biopsy, and finally MRI robotics for ICH evacuation. So that's intracerebral hemorrhage evacuation in the brain. So a little bit of our hospital here. We are the Sheikh Zayed Institute for Pediatric Surgical Innovation. We have that name from a very generous gift from United Arab Emirates, specifically Abu Dhabi, about 10 years ago. But we are the largest children's hospital in the Washington, D.C. area, and the D.C. metropolitan area is about 6 million people. So we're a 300-bed hospital. We have many intensive care units, and the model is we also have many outpatient centers around the region, and then patients with serious issues get referred to our downtown campus. And we have a three-part mission. Of course, the first is to provide excellent clinical care. We're also a teaching hospital for training pediatric residents and fellows, and finally, research and knowledge creation. And these three all kind of go together. We had started the Sheikh Zayed Institute 10 years ago. I had the pleasure of moving from the adult hospital at Georgetown to the children's hospital, which I've decided is more fun because at least pre-pandemic, we had clowns right here too. So that was always a good day when you saw the clowns at the hospital. But basically the idea of the Institute was to take some existing capabilities at the hospital in pain medicine, immunology, and personalized medicine, and then add bioengineering. So I think very much like Hamlyn tries to do, we tried to have the marriage between the engineers, the scientists, and the clinicians. And in our case, we are physically located in the top floor of the hospital, which makes collaboration very easy. So here's our research space, which was on the 6th floor of the hospital and was kind of what we call shell space. It was unfinished. So with the gift, they were able to finish all this, and we have almost 22,000 square feet or 2,400 square meters of space in the top of the hospital, which also includes dry labs and wet labs too. And we even have the capability in the basement of the hospital to do animal studies. So in terms of bioengineering, which is kind of the group I lead, as I mentioned before, the whole goal was to make surgery more precise and less invasive. So as we move to do things through smaller and smaller openings or through the vasculature, other natural interfaces to the body, the surgeon does lose their direct line of sight. So I think our job as engineers is to kind of restore that and give them the confidence that they can carry out these procedures in a minimally invasive manner. And the vision for our institute was to be an international leader in technology development, clinical translation, and product commercialization for pediatric surgery. We wanted to enable the next generation of minimally invasive procedures through technology developments in quantitative imaging, robotics, navigation, augmented reality, and theranostics, which is the combination of therapeutics and diagnostics. And we are a resource for the hospital to provide technology solutions to clinical problems. So nowadays I go in Monday, Wednesday, Friday. I'm at home Tuesday and Thursday, which includes today. But usually almost every day when I go in, one of the clinical colleagues will stop me and say they have an idea. And then we want to come discuss that. So that's really a great pleasure and really the way we as engineers should work. We should really work from what I would call clinical pull rather than technology push. So it's important for you as an engineer to understand the clinical environment as well you can if you want to work in this field. Okay, so let's get to the meat of the talk now, the MRI compatible robotics here. So again, I'm going to talk about these 4 systems under development: Arthrobot for the shoulder, Painbot for back pain diagnosis, not to apply back pain, just for clarification, BoneBot for long bone biopsy in the leg, and the ICH robot for the intracerebral hemorrhage. So why should we go to MR guided interventions? MRI is very expensive. There's kind of almost a mystique beyond the MR scanner. I think most of us know, don't bring your credit cards into the MR scanner or you won't be able to use them, as they will be demagnetized and could be a hazard. But it turns out at a children's hospital, we actually do more MRIs than CTs, and we actually try to avoid radiation. It's partially because the long-term effects of radiation, even slight amounts, are really still unknown. So while it's okay probably to have minimal radiation doses when clinically necessary, if you can avoid it, it's better. So at our hospital, we have a big push to do things under what we call non-ionizing modalities, which includes MRI and ultrasound. And finally, MRI can provide other functioning, such as monitoring of thermal treatments for what I mentioned before, which was the high intensity focused ultrasound. Okay, the one thing though about MR compatible robotics, for those of you who have ever been in what we call a closed bore MRI, which I think is about 90% still of the MRI market, access is difficult. So here I have my interventional radiology colleague, Dr. Sharma, reaching inside the scanner to target a ham phantom. The good news is, MRI, as you may know, works by kind of aligning protons, and then all the mathematics and magic happens, but nobody's ever shown any danger from being in an MRI environment for a prolonged period of time. Obviously the MRI technologists do that. We scan pregnant women in MRI as well. So at least it's a safe environment to work in there. You often want to wear headsets, as you can see here, for noise protection. But the issue with trying to reach inside a closed bore MRI is that obviously this is not ergonomic. So the idea is if we have body mount robots or other low profile robots that can work in the bore of the MRI, we can enable in-bore interventions, and we can enable real-time image guidance during interventions. And by real time, we don't mean video game real time. We mean 1 or 2 images a second, sorry. The surgeons, and interventional radiologists, of course, tend to proceed slowly and cautiously when doing these procedures. However, there are difficulties of working in the MRI environment, and you do need special training to work safely in the MRI environment here. But these are, now well known, I think, and well established. You can see from this reference from 2008, I think Roger Gassard is still in Zurich, if I remember, but that the development of dedicated high quality robotic systems requires synthesis of many fields: mechanical design, electronics, computer science and control. And MRI, of course, has a very strong both static and switching magnetic fields and radio frequency pulses, which can create safety hazards and compatibility issues, and therefore exclude the use of conventional robotic technology. So it's definitely somewhat of an art form and a scientific form to develop robots that can work properly in the MRI environment. But again, as you'll see when you investigate most things in our field, these ideas have been around for a while. So this magazine cover that I still use is from 2008, talking about MRI robotics at that time. And then there are standards now, and there are well-developed procedures to work in MRI. So the 3 terms you should know, which are going to be on the quiz, right? I think we have a quiz. I can't remember right here. But MR safe, MR conditional, and MR unsafe. So MR safe is typically an item that has no metals or ferromagnetic materials in them at all. That's completely safe. MR conditional, maybe you have to keep it outside something we call the 5 Gauss line of MRI. And MR unsafe is an item that you don't want to bring in the room, or if you do, you have to tether it to the wall so it can't go flying into the magnet and become a projectile. And you can see these symbols over here on the right, which are pretty much universally adopted. A little bit of history, and we'll just go very quickly. I'm sorry I can't cover more right now in this very short talk, but way back here, you see the double donut robot, which is Shinzai was Japanese researcher, and also this was done at the surgical planning lab at Brigham and Women's Hospital. That double donut robot is no longer available, but was a very nice design by GE, where you actually would work, the surgeon would stand between the poles of that MRI and could work in the operative field. And then the robot was designed in order to help the surgeon position instruments. We also had from Andreas Melzer in the group in Europe as well. I cannot say the German word. The German words are too long for me, where it was developed at FCK. But what had a gantry mounted low profile robotic arm here. So here was using pneumatic sensors, so not to provide any artifact. And so you can see there were early developments in this field. And then finally, the neuroarm from Calgary that I think many people have heard about too, which I think was used locally, but I don't think any of these systems were ever commercially successful. So I think the market is still open for the MRI compatible robot. Okay, we'll go to shoulder arthrography. Ferdy, anything we should comment on right now, or should I keep going then?
Okay. I think for the moment.
Okay, great. All right, I'll keep going. So now we'll get into the details of some of the systems here. So for shoulder arthrography, this is me lying in the magnet. We joke, don't try this at home, but you can see at least I have earplugs in. And this is the shoulder robot on me now. You can see my shoulders are pretty tight, although they fit into the bore of this magnet. So in the children that we aim to start this on, which would probably be starting at age 12, they would typically be a little smaller, but the robot is low profile enough that it fits in the magnet. And you can see you actually have some metal, brass and other items, which are ferromagnetic, non-ferromagnetic, sorry, so that they will not, be attracted to the magnet, but they may cause some small image artifact, but they're usually above the area to be imaged. And finally, eventually, we also, not shown in this picture, we have a body mount coil, an imaging coil that goes just under the shoulder, and then we have the coil from the table under the back, which gives us very good imaging in the magnet. So the idea in arthrography, which is injection of contrast into a joint and subsequent imaging to evaluate joint quality, is typically done under fluoroscopy in the interventional radiology suite, where they do needle placement and contrast injection. And once they do that, Then they get the next available MR slot in order to check the spread of contrast, because you really need the MR imaging to evaluate the joint condition. The main problem with this procedure can be if there is a delay in getting the MR images, there can be somewhat of a washout of the contrast and you not get a good image. And then it may also be, if you could do all of this in MRI, you could actually do more accurate needle placement as well. So we started with this procedure, and this 4 degree of freedom robot had 2 translational degrees of freedom and orientational degrees of freedom, and was designed to be low profile and body mount and serve as a needle guide to position the needle tip anywhere within the circle of this robot, as well as orient as a kind of a RCM, a remote center of motion capability. We also chose the shoulder to start because if we missed, there are not other critical organs in the shoulder that we considered it a relatively safe procedure to begin with. And we hope to actually start our clinical trial this summer. We've been obviously slightly delayed by the pandemic. But the workflow is that you mount this device on the body, and here's an early prototype built on a rapid prototyping machine and with piezo motors. Position the child in the MRI, secure the robot using straps. You get your scan, you plan your trajectory, you do image registration. So we know registration will register the coordinate system of the robot with the body. We assume the robot does not move once it's strapped onto the body. And if the patient shifts, the robot moves with the patient here. Finally, we would insert the needle and verify the position. In this case, once the robot aligns the needle, the physician would still push the needle down. So that made it safer from an FDA approval point. We would inject contrast. Once the contrast in, we would actually remove the robot, and then we would obtain diagnostic imaging. That is the workflow. The goal eventually would be to do within the 60 to 90 minutes allocated for an MRI slot. Here's a little bit of the system architecture, and you see some of the zones. So in MRI safety, you'll have zone 1 all the way up to zone 4. Zone 4 is the magnet room here. Zone 3 is the control room. And the idea is that the robot controller sits here near something called a patch panel in the room, which lets you bring the cables in and out of the room in a safe manner, and also eliminates electromagnetic interference. You always have to worry about signals coupling into the MR room here as well. And then the physician here would most likely be in the MR room, although eventually the physician could also be in the control room watching. And once it was confirmed that the robot has positioned and aligned the needle, the physician could then go in to actually physically drive the needle. Right now, we actually just transfer images by USB. Eventually, we would want to get a direct DICOM connection to the MR scanner. We also have done some work with integrated imaging coils, and this was led by Chuck Dumoulin at Cincinnati Children's, who has an excellent group for building coils. So the idea with this is that if you can have a local coil, coils are what give you signal in MR imaging. If you can have a local coil here, which is shown our coil on the top along with 2 commercial coils, and then combine them with the commercial coils supplied with the system, you can get better imaging. It usually requires you to put the scanner into research mode so that you can combine coils, but we've been able to work that out. And here we're scanning a ham phantom. We actually thought hams had some pretty good contrast right here too as well for some of our initial testing. So we do a lot of phantom, a lot of testing before we can eventually apply these things to humans. All right, so that was the shoulder robot. The next one we'll go to is Painbot, and I haven't decided if that's a good name or not, because people keep thinking I want to add pain when I want to alleviate pain. So I've been thinking about renaming that, but I think almost everyone has low back pain at some point in their life, and so it's a big clinical problem. Now here I am looking at my other side, my better side, I joke, even though we're on YouTube right here too as well. And here I am lying in the magnet. This is a little bit more of a complicated system because here we also had the 4 degree of freedom needle alignment model, but we added a 2 degree of freedom needle driver module, which adds both rotation and translation. And this was done by Julian Ordechita and Narav and Gang, all at Johns Hopkins as well, under an NIH subcontract. And the reason that we remoted the needle driver module, and they came up with the concept of the beaded chain transmission, is we did not want to have any actuators directly in line with the needle driver module. We do have actuators along the 4 degree of freedom needle alignment model, but they're spaced kind of around the anatomy. but looking right down where the needle would drive. We want to keep that kind of artifact free right here. And we were surprised. The radiologist used this on a cadaver study we did to drive some needles, and they were actually pretty happy to sit here at the back of the magnet, and once the robot had aligned the needle, to drive the needle, because we could also do real-time imaging and watch the needle path in real time. So this enabled them to feel like they were at the center of the bore of the magnet, manipulating the needle in an ergonomically comfortable position. So this is a little bit more, and there are published papers on all these too, if you want to get some more of the details. This one turned out to be easier done with Cartesian stages right here. So basically here, 2 Cartesian stages, and then for the alignment module, and then needle rotation and needle drive. It's not clear that you need needle rotation, but some people think that helps keep the needle on track, makes it a little easier to insert the needle and keeps the needle from deviating. You can also see our fiducial ring, the locking ring, and the mounting frame with the imaging coil. So all of this was made to be modular, so these type of concepts could be used in other types of areas of the body as well. And then finally, we also integrated the imaging coil. So we found there's great strength in the MRI robotics world of being able to add the imaging coil with the robot to give you better signal, and also so that you can clearly see the fiducials on the robot, which are necessary for registration. Okay, so finally, cadaver torso study. And I always have to say that this cadaver, which you really don't see, it's kind of buried under the blue sheet, was just a torso. There's actually a supplier in the US at least that you can literally order parts from. I say right here, you have to, of course, fill out a long form and justify scientifically, and it all has to be tracked. And it was improved by our infection control division. This was pre-pandemic. This was done with our clinical champions, Dr. Sharma from our hospital, and Jan Fritz, who was at Hopkins and recently moved to NYU Hospital in New York here. But the idea of the cadaver model is it's actually a great model before you go to human trials for this type of work. You know, it's truly anthropomorphic, and you know, obviously the cadaver does not respire. There has been some work with respiring cadavers, I know, with Andreas Melzer and Dundee and his Teelenbaum cadavers, but we don't have these cadavers respire. But they actually are great from an anatomical point of view for proving the concept. So here's some targeting results from the cadaver study. You can see kind of we were targeting both the facet and the epidural joint for people who know the back anatomy. You can see the needle path is pretty wide. So you do get a lot of artifact on MRI. You know, sometimes it's tough to tell where the needle actually ends, and there's a lot of work. These are MR compatible needles. I think these ones were titanium, but there's a lot of work going on with how do you do accurate needle localization under MRI. But from a concept point of view, this showed that this would all work fine. Okay, we'll go to long bone biopsy and then intracerebral hemorrhage. So here's the system concept. So this was actually from Dan Stojanovici at Johns Hopkins, who runs the urology robotics laboratory, Robotics, and that's really a great place if you ever get a chance to see Dan's work. But what's unique here is what Dan did is he made it with no metal parts and no electronics at the robot side. So the actuators are all pneumatic and the encoding is all light or optical. So this robot itself, as we'll show later, presents no interference under MRI. So the MRI purist, and maybe someone on the call will say as well, this is the only way to go. We should only build these robots that show no artifact. I would beg to differ. I say it depends upon your circumstances. The other robots we built, Painbot and Arthrobot, we can manage the artifact. So you just have to be aware of it. So I think both concepts are valid right here. But otherwise, very similar architecture in terms of you pass control wires through the patch panel. You have your planning and navigation station in the control room here. And, you know, we always say still these robots are aligning, or orienting the needle and aligning it. The physician is still in control. We are not we're not taking over for the physician. We are supplementing the physician's capabilities. So here's the reason for this. So sometimes kids will present at the hospital limping in the leg, and you want to get a bone biopsy to see if it's osteomyelitis, which is infection, or osteosarcoma, which would be a cancer, so you can take treatment right away. If you look under CT, you don't get much discrimination in the bone. So these bone lesions are really heterogeneous, and you want to sample in different places. So you can see in this case, the MRI actually gives you a lot of value in terms of the imaging as well, and the ability to discriminate the tissue here. We had done some phantom studies here, a little bit hard to see. It's maybe best seen at the bottom right. Here's a long bone, a leg phantom suspended in gelatin, then with a cutout. Here's the MR robot here with the pneumatic cables, and it basically has a remote center of motion needle guide right here at the end. So again, we could do the path planning, we could align, and we tried to target this bone phantom. Here's a little bit picture of the long bone phantom and the different targets that we put in it right here. And then here's some very nice simulations from Dan's group right here, kind of showing the targeting of the bone and the modeling right here, and trying to see how we got target accuracy as well. And at the end, the results are pretty good. You know, if you read journals, everybody reports millimeter accuracy, you know, which I don't think we get in the real world. Here we had about almost 2 millimeters of error. I think a couple millimeters are still going to be clinically acceptable. We can never quite get, you know, of course, from the clinicians how much accuracy they need. They're saying, of course, we get the needle where it needs to go, but we think a couple millimeters accuracy is good. Okay, let's go to intracerebral hemorrhage, and then we can wrap up. Okay, so this is a completely different topic. So we've switched from the shoulder to the back, to the leg, so now to the brain. So a complete tour of the body today. This is intracerebral hemorrhage evacuation under interventional MRI. So the idea for this project was to explore whether ICH evacuation under IMRI, interventional MRI, is feasible and provide a new treatment paradigm. Right now, this is done under CT, and it is a surgical emergency. Okay, the advantage of MRI is delineation of white matter tracts right here, enhanced visualization of the underlying pathology, and of course the lack of radiation, which means you can acquire more scans during the procedure. ICH is clinically significant. It is an adult thing. It's not a children's thing like most of the other things we were looking at. Occurs in approximately 2 million people worldwide. ICH cases have been growing up, and the 30-day mortality rate is extremely high. So if you have an intracerebral hemorrhage, which is normally manifested in a stroke, the window to get treatment is very short. So the sooner you can get a treatment and the better you can evacuate the hemorrhage, usually the better the clinical prognosis. Here's just a little picture of some of the procedures right here and some of the instruments. Here's what happens with the hematoma. Blood vessel burst, blood fills the space inside the brain. Here in the middle, this is called open craniotomy, where they remove some of the skull right here and relieve the intracranial pressure. And then here's a little bit of a neuroendoscopy device, a more minimally invasive fashion. So we want to do these in a more minimally invasive means through a skull burr hole. So here's the concept for this proposal we were recently awarded by NIH, is that you would have a concentric tube robot that would sit back here. You would be in the bore of the scanner. You would drill the burr hole, and then you would use this device, and then you would be able to steer through here with real-time imaging, and the clinician could control the robot to evacuate the clot. So in this case, the clinician would really be relying on the robot to evacuate the clot, but would be able to monitor in real time. Here's some of the work with the ICH robot. This is from Wei Chen at University of Arkansas right here. And, you know, there's been other work in concentric tube robots in the literature. The idea is you would come down to the clot in a straight path, but then you would have a concentric tube robot where you could steer around to evacuate the clot. So here's just some of the diagrams of the size. You could potentially do this through smaller burr holes as well. Although sometimes if the clot is very sticky, you need a little bit of a wider cannula to be able to evacuate it. And then here's the idea with the concentric tubes here that many of you know. You kind of come straight down into the clot, but once you deploy, you can then use the curved tube and steer it around to evacuate the clot. Of course, these are all just concepts right now and need to be shown throughout the research plan. So there's a little bit of a visualization of that. And then the user interface. So one thing I didn't mention is we have been working with 3D Slicer for other projects as well. And we do have some software for robot control. So if anybody's interested in getting a copy of that or share that, you know, we strongly believe in the open source movement. And in this one for the ICH, it would be nice. We do plan to integrate diffusion tensor imaging, which can help surgeons avoid critical regions in the brain. So we think that would be another plus. So I think I did it in record time here. In order, let me just go to the conclusions and then we can have some discussions. That MRI robotics continues to be an emerging field. We do feel the benefits could be substantial in multiple clinical areas. There is a high cost, of course, to working in the MR environment, but there are some lower cost things. You may have heard the portable MR scanner from Hyperfine has now come out, and we have one at the hospital. So, could we eventually use tools like that for interventions as well? There have been some commercial systems too in the MRI kind of robotics area. NeuroBlade is one example. But the real need for us as researchers is to continue development and move to clinical trials. I strongly believe that ultimately our goal needs to move to trials so we can show the clinical utility of what we're doing. And of course, for that, we need to work very carefully with our clinical colleagues. And finally, of course, the research funding is critical. So we've been very fortunate to be supported by NIH as well, but that would not be possible without that. So there's a picture of our hospital. We kind of say the spaceship building. We're up here up top with a nice view of the city. You're certainly welcome to visit when the time allows again. And these are just some of my acknowledgements from my institute, from the different Hopkins group, the Urology Robotics Laboratory, INSIST, the ICH robotic colleagues, which includes the neurosurgeons, Dimitri at GW and Chris Kellner at NYU and Chima from our group. And finally, the funding, thanks to the sponsors that make it all possible. So with that, thanks for your attention, and we can go ahead and I guess start the discussion.
Kevin, thank you very much. This was great, and a great primer for MRI compatible robotics, which quite a few of us have dabbled in to a lesser or greater extent. So we have now got some time for questions. As I typed into the chat box, you can either ask your questions on the chat or in the Q&A, and I will then endeavor to share these with Kevin so that he can reply. We have a first question from Christos, and it says, "Thank you for the excellent talk, Kevin. Pleasure to hear the entire research on MRI compatible robots. I am familiar with a few systems that started commercially, e.g. InnoMotion comes to mind, that seem to be fantastic engineering achievements, but did not end up succeeding in the market. What is your opinion about the biggest risks to commercial translation?" And it's a question I had in my head as well.
Yeah. Thank you, Christos. Yeah, I think that's an excellent question. And, hopefully we're going to have the interventional MRI meeting in Leipzig later this year, right here. I haven't quite seen the final decision on that, if it will be in person, virtual, or hybrid, but that's always the topic of discussion. And I've gone, maybe now the last 6 years or so, but it's usually every other year. And each time they say, oh yeah, commercialization is right around the corner, next year. And I think it's really still a niche market. It really is, of course, the question always in medical, is, what is the reimbursement, and what is the advantage, that you're introducing versus existing clinical practice. So I think it's still a little bit of a struggle for MR robotics, but I think we can take heart in all the recent developments in robotics in general. People may complain about Intuitive being the big grill in the field, but since Intuitive was successful, now we're seeing other successes in robotics. We're seeing Medtronic get into more. So I think the biggest risk is still, showing the cost benefit. If I'm only doing procedures we currently do, but a little better, I don't think that's enough. I think it's when the robot can eventually enable new procedures, real-time imaging of laser ablation inside the bore of the magnet that we'll see that. And we should think about it. But as researchers, I think, our main goal is to push the envelope so that will be possible someday. So sorry for the long-winded answer, but that's my thought.
Thank you, Kevin. Before we go to Elena's question, I had a bit of a follow-on there, because as someone who has personally started to work on MR compatible robotics, one of the biggest issues is not even commercialization, but it's actually closing the loop around the magnet. Because of course, you need active involvement from magnet manufacturers, the Siemens of this world. And that is or isn't possible depending on a plethora of other things, which are not necessarily whether you've got a great idea or great tech. So I don't know whether there is some sort of insight you could shed on, are there ways to lure magnet manufacturers to work with you, or is you just sort of have to bank on the fact that the hospital you work with has a great relationship with Siemens and they can basically twist Siemens' hand to give you access to some of those images in real time, because without them, of course, there's not much we can do.
Right. Yeah, I think first of all, what we try to do is we try to make all our systems right now DICOM compatible. so that we are just relying on what we used to call sneaker net, which is kind of, you write to USB and then you move it over. Now, that doesn't work when you start getting into real time and you want to send real time feedback, because then you need a research agreement and you need access to those interfaces. So that is a struggle. I think, you have to be big enough or somehow or other get on the radar of these companies. We have struggled with that as a pediatric hospital. We've certainly worked with Dr. Fritz, who was at Hopkins and now at NYU, because, I think what the companies want is a leading clinician, who's pushing the envelope, and then, maybe they'll support the research program. But I think that's a huge challenge, because in some sense, without that access to do very advanced things, you may not be able to. But I think you can do a lot with just DICOM right now. So I don't think it's a showstopper, but it's certainly an impediment.
Elena has a question, and it's more of an engineering question. So thank you very much for the great overview. How does the long-term wear and tear of plastic robot bodies compared to steel and aluminum? Is plastic inferior?
Yeah, I may even ask Julian to comment after I finish if he wants to, because he's been building these. But my personal feeling is 3D printing has gotten so much better. And again, we, that the materials are tougher now. Now, when we're building prototypes that we're just putting through limited trials, we're not really stressing them the way, so we aren't going to want to go to steel or aluminum, in the MRI environment. I think the plastic, and I don't think we have huge stresses on what we do. So my personal experience is the rapid prototype, robots and everything that we've been building are fine. How they would hold up in the long term, I don't know. Can we enable Julian to comment if he wishes? Is that possible?
I think we can actually. So as Marianne tries to see whether we can upgrade Julian as a panelist so he can actually share his views verbally, I have a slight follow on.
Okay.
Which again tallies with some of the experience we've had. So I saw some hydraulics, maybe some pneumatics even, and obviously some piezoelectrics. So, and they all have their pros and cons. Do you have a favorite, or do you think it's sort of the right thing for the right job?
Yeah. I think you said pros and cons. And sorry, Julian, for putting you on the spot. I think people who know me know that the danger of listening to my lectures, I may call on you. So let me answer that one, and then I'll ask Julian to comment. But anyway, I think it really depends upon the job. I mean, I do think actuators are a limiting factor in MRI robotics, just like in robotics in general, right? I think we've all been kind of wanting the magic actuator still in robotics, for the last 20 years, which, while they've gotten better, all actuators, for us, it's limited. The piezo motors don't have much torque, but usually we don't need use torque and we move slowly. The pneumatics are typically custom developed because there's not really a commercial pneumatic motor as well. I'm not a big fan of hydraulics in there just because of the oil and control right there. So I'm a fan of pneumatics. But can we let Julian comment now? Is that possible?
Julian, it's great to see you, and thank you for joining in on this webinar.
Could you hear me?
Yes, perfect.
Nice talk, Kevin. Thank you very much. And also nice question about the plastics. So basically, we are using 3D printed plastics now, but also as Dan Stoyanovich did, we could use good plastics like Altem and PIC, and those are like 3 times, comparatively to aluminum. Also, it's possible to use ceramics, 3D printed, but also machine. So in my opinion, I guess we have good materials to MRI safe to use for building these robots. Now, also, we are trying to combine plastics with non-magnetic metals. And in our last 5 or 6 years collaboration with Kevin, we learn a lot, how to combine them and where to use and where not to use such a kind of metals. So I will let Kevin to continue. Thank you very much.
I think actually Loris's question is for both really, because again, talking about non-ferromagnetic metals, Loris asks, you mentioned that the solution, one of the solutions you're looking at is concentric tube robots, which we know are generally made of Nitinol. And I was wondering if you could share any insights on the type of artifacts that the material can create in MRI images, and are they significant? Do they represent a problem for tracking accuracy and guidance? So it's definitely not a big artifact, but is it big enough that around your ROI, so your region of interest, you'll then have issues? Oh, you're muted, Kevin.
Yeah, thank you. I'm looking to see if my colleague Wei Chen was on from Arkansas who built that, because I haven't actually tried those robots yet in the magnet. So I hate to ask again, Julian, but what about the nitinol? Does the nitinol give artifact, or is that okay in the MRI?
So as I know, nitinol, obviously it's non-magnetic, but the artifacts in MRIs, they are less than titanium or those non-magnetic stainless steel. Still, you have some artifacts because it's a void in the image. So we need to see how it's working into the brain.
Yeah, so my own experience is you absolutely can deploy Nitinol, yeah, especially if you have a small cross-sectional area. But the problem is there will be a loss of signals or an increase in signal-to-noise ratio right around the area, and with concentric tube, that's the area you care about. And so obviously that may create some issues that'd be worth looking at, with the caveat that with machine learning, the progress in artifact reduction is absolutely astonishing, almost science fiction. I am I'm not completely late to the area, and I'm surprised about how incredible the images, how incredible some of the images come out the other end of a properly trained network, especially in image processing. I've got another question, which is actually a rather interesting one, right at the sort of the state-of-the-art end of MRI compatible robotics, and it is from Xiaoguang, and I apologize in advance if I mispronounced your name. And the question goes: how do you see the potential and limitations of utilizing MRI to actuate magnetic end effectors, such as particles and other untethered devices, in comparison with the tethered MRI compatible tools and robots? So basically, that is piggybacking on the MRI gradients to actually get small devices into the body and through particular paths.
Yeah, I think it's a very interesting research area right now. I think, again, as I said before, we need to think of, research should still push the state of the art forward. I would still say if that's something that you want to work on, you should at least have a clinician that who would be interested to kind of guide you. I mean, nothing wrong with pure research again, but my preference in this field is to have still clinically directed. There has been also a lot of work with our ENT doctors, our ear, nose, and throat, about magnetically actuated particles in the ear to clear ear infections. So could you steer the fluid? So could you do that type of thing in a magnet? I think it's possible, but I also think the hurdles and then the path to clinical translation and showing the safety of that and that it behaves in a predictable manner is quite a challenge. So I would have nothing against that work, but I think it's still challenging and very much a research field, in my opinion.
Yeah. I have one more question, which is slightly contentious to us. One in the sense that we have done some own work at our end on interventional MRI in the context of endovascular surgery. And there's sort of two camps there. There are those clinicians who think, yes, MRI, so the advantage of deploying within the bore of an MRI and the 3D imaging and the real-time feed that you can get from it definitely outweighs the cons of having to be restricted to an interventional unit like an IMRI unit. And then those that say, absolutely, well, I mean, this is just, complete engineering push. What are you doing investing money and resources there? We've got bigger problems, bigger fish to fry. So do you think that over time we will reach a better consensus, at least in the adult patient population, or does it continue to remain a bit of a mixed bag?
Yeah, I mean, I don't know that we'll reach a consensus, but I do feel that it's worth pursuing. Again, I would say, when I wouldn't have even thought about it before I came to the Children's Hospital. The one issue, of course, is MRI reimburses very well. And imaging is still a big moneymaker for most hospitals. So to say you're going to need a dedicated magnet for interventions, when you're not going to be able to run imaging studies every hour, and bill for those in the technical fee, we know that finances still have to drive hospitals. So, but
that works for the US system, for the UK system, not so much.
Maybe not, because you guys have, that's true. But either way, I mean, I think what you need is a clinician who believes you know, and all these things. And we do, you know, both Dr. Sharma and Dr. Fritz, you know, they are doing things in MRI, you know, and I can tell you from that leg bone case, if you're doing a bone biopsy and MRI, you get so much better visualization and you're so much sure to me, which ultimately will lead to a better clinical outcome. So that physician will say, I want to do it. Now, does the system currently reimburse for that? You know, maybe again, not an issue on your end for us. So I think, again, it's, you know, that's the thing about medicine. Engineering, it's black and white more. The equations show this type of thing. You know, I think clinical practice highly depends upon the practitioner, you know, local conditions, their interest in what they think is best for patients.
So my own gut feeling is pediatrics interventional MR is certainly almost like the perfect use case for the deployment of this technology, because it's small patients where it's a lot harder to actually get things accurately to the right place. And of course, ionizing radiation in the children is a significantly higher risk, as in pregnant women and so on. So for all those reasons, I think if there was one area of where there is less friction to let's say larger scale deployment of this tech is certainly pediatrics. But I guess it's early days still. We'll see what happens in the not too distant future. Are there any other burning questions? If not, I would like to thank our esteemed speaker for taking the time to share his thoughts with us. I wanted to remind you all that the talk is recorded, and so for those who were not able to join us live because of, if nothing else, time constraints, given this is broadcast globally, you're very welcome to go to the Hamlyn website or the YouTube channel, where this particular recording will be available to you free of charge. The other thing I wanted to remind you is that this particular talk kicks off a whole range of activities, and I'm sharing with you the Hamlyn website. So the timeline here that gets continuously populated, and Marianne will confirm there are many more entries that are happening between now and the end of July. And so I would encourage you to keep an eye on the website, and you'll see that on this Friday, we have actually our first workshop/webinar, and it's one that I actually had a significant stake in, because it is the output of a almost year-long journey trying to put together our thoughts as a UK healthcare or surgical robotics community to map out the future of UK surgical robotics. And so we'll be discussing a draft white paper on Friday. And then, of course, next week, we've got our next keynote speaker, which is Rich Satava, who will be sharing a talk with us. So please do join us again, and I look forward to seeing many of you soon. Kevin, thank you again. And Julian, thank you. Great to see you, and thank you for your contribution. We'll talk soon.
So, Ferdy, can I give a 1-minute answer to the last question before we sign off?
I didn't even see it, so thank you very much for alerting me to it. Yes.
Just real quick, the question about FDA and regulatory. It's really no different than any other device you build, at least in the US. So if you want to build a device in the US and apply for a study at your hospital, you either need to get your IRB approval first from your ethics board, which can declare the device to be non-significant risk, no more than the risk of current devices, or if it's significant risk, you need to get FDA approval. So we just work through all those processes, and it is a little bit of a challenge and a paperwork issue, but we deal with both the IRB and FDA, and it's addressable. So I just want to close on that and thank everybody, and Ferdy, thank you, and Marianne for arranging things. It was very well run then.
Wonderful. Thank you, Kevin. Thank you, everybody. See you soon, and have a safe rest of the day. Take care.